Next up, we have Dr. Rodolfo Savica, who is a professor of neurology, a practicing neurologist, a movement disorder and behavior specialist at the Mayo Clinic in Rochester, Minnesota. He's also a PhD. He has a particular interest in early onset Parkinson's and initiatives regarding the clinical practice and research of early onset. And he is the chair of the International Movement Disorder Society Task Force on Early Onset Parkinson's. And he leads a lab with the goals of finding a cure and improving the quality of life for people with Parkinson's. Welcome, Dr. Savica. Thank you so much for being here.
Absolutely. It is my pleasure. I would like to, first of all, thank everyone and Davis Foundation, Phinney Foundation. Thanks all the previous speaker. Thanks, Melanie. Thanks, everyone that I had the opportunity to listen to talk to, and the foundation that gave me the opportunity to talk to you today. I wanted to say right away, the Phinney Foundation is doing an excellent job to fill, as we heard earlier on, Mr. Phinney talking about that was the purpose, fill the gaps that are there for young onset Parkinson's disease education, networking, and trying to put people together. That is a very important mission, and we're going to talk more about it. I decided not to prepare any slides, not to put slides on for a major purpose, because I think that our audience, everybody, have heard 50 million times about Parkinson's disease, what it develops, how it goes, what are the proteins. And the problem that we have in this situation is that we are talking about a condition that is not a real one. It's not what we're facing here today. We're using knowledge of a condition that affects people in their 70s, and we are translating it in a condition that is affecting people in their 40s, 50s. The important thing that a couple of few messages I want to mention is that the biology underlying the condition, the young onset Parkinson's disease, is absolutely, totally different than what we see in late onset Parkinson's disease. So then why we call Parkinson's disease if a different condition? Well, we don't have a better term, I would say, not so far. And in the past, there was this tendency to put together, to clump together this condition as one. We know now that we are not talking about one single disease. We're talking about a number of diseases that have different biology that are ending with a degeneration, with a death of some of the neurons of the brain. But the final outcome is caused by a number of different problems, not by the same problems. So that's why talking about alpha-synuclein, talking about the deposit of Lewy bodies in the brain in somebody in his 50s and 40s, I don't think is going to be a good idea, because it doesn't represent the real truth here. From a biological standpoint, what we know now is that for reasons that are yet quite unclear, there is a group of cells, the cells of the basal ganglia, the famous cells of the basal ganglia. So the nuclei of the caudate, the putamen, nuclei that are indeed involved in Parkinson's disease. The for reasons that we don't know, in younger individuals can be affected earlier on by a number of other biochemical pathways that are causing a damage that is equally similar to what we see in late onset, but is different. What is difference about? So in late onset, we do have an accumulation, a lifelong accumulation of alpha-synuclein, something that starts likely in our 20s, with no symptoms or minimal symptoms, and with time, it grows, it affects the bowel, It affects the olfactory bulb, so causing people to have anosmia. It affects the tendency at night to have insomnia or having agitated dreams. And then after 20, 30 years, 10 years of mild symptoms, then people are having tremor, people are having rigidity, people are falling. Therefore, the diagnosis of Parkinson's disease starts. That would be totally fair and right if we are talking about Parkinson's disease in general. But we all know we have 136 participants, and I'm pretty positive that what we are indeed experiencing as a group is not what I just told you. I don't think that many people experience for many years constipation. I don't think that people experience for many years dream and and behavior disorder before they start. I don't think that people have anosmia for a long time. What does it mean? It means that the biology is different. It means that right away in younger onset Parkinson's disease, we have an immediate damage that is faster, is somehow more precise, less slow in progressing, that affects specifically the nuclei, specifically that cells. Just one question, I want to tell you, I see you, I don't see me talking. I don't know if the audience are seeing me talking or you. I want just to make sure.
Dr. Savica, I just want to jump in for a second. So there are some questions being asked, but I will take them from the chat and ask them to you.
Makes sense. But I want to make sure. I don't know if they see you or me when I talk.
I hope that they see you. Yeah, they see you. And then I will. I don't want to interrupt you, but I'm good.
No. I see a little version of me. That's why I'm asking.
Okay.
Technological issue, but that is an important thing. A much more focused, a much more precise damage toward the basal ganglia. Coming, as I mentioned, for different sources. What are the different sources? I think that this is a moment to understand that we are dealing with multiple diseases, even young onset Parkinson's disease. I'm pretty sure that what we just saw, what we just heard may apply to some, but not to all. What we just saw, what we just heard is different in all our 136 participants. And everyone has the need, and we have the necessity biologically and in terms of treatment to understand the differences and to customize the treatment. Make sure that we are dealing with a unique pathology. I want to mention, and then we're going to talk more about some of the questions, and totally happy with that, but there's a couple of things. Nowadays, every patient with young onset Parkinson's disease that comes to my door has been heavily tested to look for what I call mimickers. So conditions that are called Parkinson's disease or Parkinsonism, because this is the way we call it. Why? Because the symptoms are tremor, rigidity, stiffness, falls, but they are inherently different because they have a different biology. I'll give you an example. A very common condition is Gaucher disease. Gaucher disease is a pediatric condition that seems to be affecting more Ashkenazi Jewish people and affects the kids, causing a lot of GI problems. But we know that if a patient is carrying one gene only, not two, one defected copy, so if you have two copies of the affected gene, then you have Gaucher disease. But if you have only one copy, and maybe another gene that is not yet clear, a variant of what we call a variant of uncertain significance, people may have Parkinson's disease. People may look like Parkinson's disease. People may have a metabolic condition characterized by an increased level of one group of protein that are belonging to the class of lysosomes, causing a damage similar to Parkinson's disease. Why this is important? Well, give you an example. In a situation like that, there's some ongoing trial about potential medications that are available in Europe already over the counter that can potentially block this accumulation of this excessive amount of proteins. I'm working heavily on that with some colleagues from Israel, but unfortunately, a couple of things happen. Other than coronavirus, As you may know, just a couple of weeks ago in Israel, there was some sort of war, some sort of attack. So this delayed many things with my colleagues in Israel. But guess what? I'm working with the pediatric people. I'm not working with adult neurologists because they are not aware of that. I give you an example. If my patient's coming back with this result, then I had to involve a pediatrician, one of my colleagues, which is an expert on this particular pediatric field. But I give you Gaucher example, I give you another example, Pompe disease. Pompe disease is an incredibly rare condition, but it's again caused by an accumulation of some proteins that are membrane proteins that are important for the neuron's well-being. But we had to search for that. Why? Because if somebody has a Pompe disease, if somebody has Gaucher disease, if somebody has other conditions that are rare, mimickers like Chidiac-Higashi disease, rare conditions affecting the kids that then can linger in the adult, they may not respond to the medication. They may not absorb the medication. And therefore, the delivering of carbidopa-levodopa, whether you do immediate release, control release, inhaler, or whatever, is completely impaired. And that is a problem. In terms of customization also, that we have to think. So, and all my patients are coming, we have to study the biology of each single individual. But then, one thing that we do, almost in everyone, we end up looking at the genes, but not because genes are the genetic background, it is the answer to all our questions. Because sometimes, many times, some genetic defect, genetic mutation can explain some paradoxical response of the treatment. And it's very important. I give you an example. I was hearing before the idea of slowly increment carbidopa-levodopa, which is always what we do. Whether it's coming in quarter or in half is always what we do. But there are some genetic mutation caused by a defect, it's called PARK2. When people are having this PARK2 mutation, which is a more benign Parkinsonism, so something that doesn't progress as fast, very small doses of carbidopa-levodopa can cause a lot of problems, can cause dyskinesia, can cause dystonia, can cause a paradoxical response, way more than what we see later in life, way more than what we see in our patients. So the entire idea of understanding the biology of one individual is exactly this. I need to be knowing what I'm dealing with. And what I'm dealing with personally is different than what the other patient next door would work with. I'll give you an example also, and it's important. I really like the previous Mrs. Queen was very good talking about all the young patients. I always say to my patients, once you're a young onset patient, you're always a young onset patient. In other words, you will behave a little bit different than the older individuals. But obviously there's age comes along. So if somebody starts with a Parkinson disease diagnosis in his 40s, then his 70s or 80s, and still has the condition that there's aging ongoing. But for example, I recently seen an individual that has been having this mutation, PARK2, for about 20 years. The disease is not progressed, but every time I give a smidge of carbidopa-levodopa, there's massive reaction. So then we have a problem to what to do. But the entire goal is to really focus on customization of treatment, prognosis, and medical and non-medical management. So medical and non-medical management. My entire recent, in the last few years, I try to dedicate myself to develop a different idea regarding young onset Parkinson's disease. The idea is to have a complete holistic approach that goes from medication, from prognosis, for sexual dysfunction, from social aspects, for exercise, and go on. And we're going to talk more about some of these aspects because those are part of our life. And it's indeed very relevant that we do that. One thing I want to mention that is also quite important for a biology standpoint one of the big original sin, let me pass a biblical term, of young onset Parkinson disease is to think that people that have young onset Parkinson disease have a strong family history of Parkinson disease. It's not the case. It is possible, but not the case. Many people, I'm sure many of our people that are in the audience here, do not have anybody in the family with Parkinson disease, despite they have young onset Parkinson disease. This original sin came to the fact that the first studies looking at young onset Parkinson disease were looking at young individuals that were part of large families. And this prompted to identify about 26, 27 genes that are the most common genes of Parkinson disease that are indeed relevant for the prognosis, and they can tell us more about it. But these 26 genes that usually are commercially available are showing only a really partial part of the truth. They show only the group of patients that are positive are the one that can have maybe some sort of familial history, or maybe they don't know they have. There is an important point because the vast majority of patients do not have a strong family history. So when we look at the genes, we are looking again at a very small portion of the truth. And I keep saying that, and it's an important thing.
Dr. Savica, can I ask you a question that sort of frames up what you're talking about?
Sure.
I know I've heard you say before it's difficult to define what young onset is versus what early onset is. Can you explain that a little bit more?
Hey, let's ready, yeah? Let's ready to fight, okay? Okay, no, I'm joking about it, but it's an important point. One of the first purposes of the task force that I am honored to be the chair of is indeed to have a clear-cut definition of the age. And this is a problem. This is a problem because age is different. The consideration of early, young, or not is something that depends a lot in terms of culture, as cultural difference, as country differences. I always give the example, and somebody already heard about this example. In Australia, 65 is the age considered young onset, just because it's the age of retirement. I don't know about that. You know, it's not necessarily the truth there. I think that currently young and early onset are considered synonym. I say early onset when we are talking about something that is earlier than what we are expecting in the population. The age of Parkinson's disease in the population, the median age is about 65 to 70 years old, more or less, in terms of onset of the motor symptoms of Parkinson's disease. So everything before that can be considered earlier onset. Nowadays, the idea and the nomenclature seem to be moving more toward the idea of using the term young onset, which I like a little bit more. I was not convinced about that, but now with time I convinced myself it's the best term, young onset. And the idea is to use more or less 55 in terms of age of onset before 55. But then you say, what about somebody 57, 60? Where are we going with that? Well, they are still considered early onset to some extent, but we don't know in terms of biology, are we dealing with somebody with an earlier biology or with a later biology? That is an important point because, as I told you before, this changed completely the way we treat the condition. And that is an important thing, an important thing, because that is a major fight. I'm serious about it. That's why I say let's ready to fight, because that is something that constantly, and I'm losing years of my life trying to put together, my colleagues and not only my colleagues, but also reach out to some patients and patient group, and everybody's having different ideas. But why is it important to define? It's important to define for research, but it's important to define also for legislation, to advocate, right? If, let's say, the Phinney Foundation wants to go in front of the Congress to advocate more resources for young onset Parkinson's disease, the first thing that a congressman would ask is that, okay, what is the age you're talking about? And if you're vague about that, that is not going to be good. So that is seem to be a silly dispute, but is an important dispute because it has biological and also practical, very practical implications. That's an important thing. I hope they answer the question, but it's not very easy to answer this question. I have some other questions here that are actually very, very nice, and I think I can cover some of them as I speak a little bit. For example, somebody say in Canada, young onset is under the age of 50, somebody wrote, perfect. And you see, that is not stable across, is not defined across the different countries, even in North America. If you ask 10 colleagues, 10, as somebody says before, so-called movement disorder expert, that was very funny. So movement disorder expert, a little bit insulting, but fine. I'm just kidding. I'm just kidding. And somebody said, can you give me the definition of young onset? You get 10 different answers. Trust me, you get 10 different answers. So it's something that we are required to adjust. And we are trying also to educate. I don't want to drift a little, but it's important. Education, teaching residents, teaching future movement disorder experts, that we are not dealing with Parkinson's disease. Our patients are in their 40s and in 50s, they are in top of their life. We are not dealing with patients, with all the respect, in their 80s or 90s. Again, with all the respect, we need to deal with these patients as well. But there are some social, some situations, some issues. Kids are young, people are still working. If we do not educate that there's a difference there, and if I don't start doing that, we don't start to do that, there's a disaster. That's why I like a lot your foundation, because it's trying to do that. And it's a very important thing. One thing I want to tell you, let's move because I'm concerned I'm gonna run off of time. I want to divide in a few times. I want to answer some question. Okay, let's say you see your physician, whether it's a so-called movement disorder expert or a neurologist or whoever. You receive a diagnosis of Parkinson's disease. What to do? What to do next? Okay, you make sure that all the mimickers, you did all the tests, all the scans, all the genes, everything is pointing to, okay, this is a young onset Parkinson's disease. Maybe you're 48. What do you want to do? What do you need to do? Well, I need you to treat you now. We need to make sure that you're good now. I really like what Mrs. Quinn said. I wish I would start the medication earlier. I wish I didn't defer anything for later. That's important. I always give the similarities, the analogy with diabetes. If somebody has diabetes and the glucose is too high, we can try as much as oral agents we want, but ultimately we need insulin. Our insulin here is levodopa. And there's a point that we need to use it, because otherwise people cannot move. People, as mentioned before, cannot exercise correctly. People can be slower, people can suffer. And we are not talking about movement. Sometimes levodopa is helpful for mood. Many times it's helpful to increase the mood, increase the memory. As many patients says, I have brain fog. Why? Because the dopaminergic system is not yet stimulated correctly. So first thing is to find a treatment that works for yourself. Whether it's a quarter of a tablet, whether it's 3 tablets, whether it's a different drug, it's okay. You have to partner closely with your physician, and we need to tell your physician that the patients know the body better than anybody else. I don't know your body, especially if you know about, dancing or martial arts, or you're very well aware of your body, or you're an athlete. You know the body better than anybody else. So you can tell your physician, what is your requirement, your daily requirement of medication that can vary according to the days and according to the physical needs. What I mean with that, I want my patients all to exercise, all of them. But clearly, if you have somebody in their 40s and 50s, I want them to exercise regularly. I want them to go, they want to do boxing class, good, go to regular boxing class. I have some people doing grappling, wrestling, go to regular wrestling class. But then you say, you know, Dr. Savica, the problem is that when I go to this class, I am feeling good, but not necessarily immediately. Sometimes I feel that I need more cinnamon. Okay. Before class, that particular day you go to class, you take a little bit more. And we customize, we tailor the treatment according to your individual needs. But then you say, okay, but what about dyskinesia? I'm terribly worried about dyskinesia. And you're right. There are some group of patients that have some specific mutation, specific genetic characteristics. They make them more at risk of dyskinesia compared to others. Our current study shows that 52% of patients at 8 years with early onset Parkinson disease, defined before the age of 55, they experience some dyskinesia. Some of them is really modest. Some of them are having severe dyskinesia. But this means that 48% are not developing that. 52 are, and this means that dyskinesia, as shown before, requires some adjustments, requires some clear ownership from the doctor and from the patient to adjust according to the needs and according to what we can do. But people can tell you, I have many patients say, I prefer to be dyskinetic than be unable to move. And this is a true story. It's something that we are required to find a balance according to the needs. So despite dyskinesia, it is considered a very severe and bothersome symptom, is not necessarily something that we can battle and we can work together to improve it in the vast majority of cases. That is an important thing. And it's true, is the more medication I give, the more dyskinesia there's a risk of, but sometimes even small doses can cause that according to the individual needs of the patient, individual characteristic of the patient. One thing I want to mention, because the other part of my talk was living well. So treatment, as we know, we have one gold standard medication, which is carbidopa-levodopa. We have dopamine agonists, we have other medications that are used at times, but the gold standard is still carbidopa-levodopa. What about deep brain stimulation? Is the brain stimulation the last beach, the last resort? Not at all. Deep brain stimulation is a procedure that can be done, needs to be done when it's needed. Sometimes it can be very early in the disease, sometimes it can be later in the disease, but it's done when it's needed. It's not the last resort. And it's important to see, what can I achieve with the brain stimulation? I have a lot of tremor. Fantastic. That works for you very well. I don't have a lot of tremor. I'm more stiff and rigid. Would this work for me? Maybe not as much, but I'm generalizing here, but it's important to consider deep brain stimulation as a possible tool that we have, but it's not the last resort. And it's an important thing to consider, because that is what some of my colleagues wrongfully are thinking still. And it's coming again to try to translate information from a different disease into young onset Parkinson disease. Another little thing about living well, so exercise is crucial. I always tell my patient pleasure. Pleasure doesn't mean doing exotic things. It means carve time for yourself. Pleasure also is part of having a fulfilled life, which I like. I heard even Mr. Phinney say, please live your life at your best. And it's exactly what we need to be doing. This condition has a social stigma that we are still working on, and it is tough to remove. But it's a condition that once there, nobody would like to have it, but we have to face it, but you have to have a full life. This means, please be vocal with your physician, be vocal with your friends. If the antidepressant that you're taking is causing you to have urinary retention or is causing to have erectile dysfunction, tell right away. Those are examples of practical things that you can see. If you see, and if your physician doesn't want to change it or blow you off, change physician. I'm sorry to say that, but it's the way to be doing at times. If you don't find a good connection, or somebody that is willing to work with you customizing the treatment, that is not the right choice, okay? That is not the right choice whatsoever. One thing that I want to mention, I'm very big into supplements and diet. But supplements need to be cheap, need to be making sense. All my patients, as you may have heard many times, are using folate, B6, and B12, all of them. And all of them are eating more flavonoids. So little chemicals that are present in the skin of purple and blue vegetables and fruits. What about all these very expensive supplements that you find online that are claiming this or that effect? Are they detrimental? Not necessarily. Are detrimental for your pocket? Absolutely. They cost a lot of money. Do we have strong evidence that this would work? Not necessarily. If I do not have strong evidence that something would work, I don't give to my patient because I am not happy about giving something just to try. That is for sure. And supplements, there's so many. One thing I want to tell you right away, and please bear with me, and then I want to answer some of these questions, is what about natural carbidopa levodopa? I don't take Cinemet. I am anti-drug. It's a normal thing I hear. I am anti-drug. I'm against big pharma. I don't want to use it. I don't want to take drugs. But I found this particular bean called Mucuna prurens that I can use instead of carbidopa levodopa. Is it wrong? No, it's not wrong, but it's not right. So what is the problem? Mucuna prurens is what we use to extract dopamine to put in the levodopa. But every plant, every single plant of Mucuna prurens has a different amount of dopamine. Sometimes you get 50, sometimes you get 70, sometimes you get 25. So we don't have a clear dose that we can use. In addition, what is carbidopa? Carbidopa is used to kind of kill the nausea, block the nausea. Mucuna prurens doesn't have that. So there is an increased risk of having people really vomiting and having major puking if they use that. It is used in developing countries. It is used sometimes in Africa when there's no access to the drug. And I'm okay with that. But I don't see a good reason why using it here when we can have a much purified, and as you heard before, we need to customize little doses. Sometimes a little change of the dose can make a world of a difference. So I usually suggest my patient not to go that route. Some people are doing it. I am more than say I don't recommend it. I don't know what to say, I would say. Now, if it's okay with you, maybe for the last 15 minutes, we can more or less we can answer some questions. Some of them are very interesting, actually.
Right. Okay, so I'm going to ask this question I thought was super fascinating. Research suggests reducing the amount of alpha-synuclein in the system is a possibility of slowing the progress of Parkinson's, much as the forthcoming someday repurposed meds will do. Is there a possibility of needing to have a certain stage of Parkinson's to have them work?
Melanie, what a great question. So I really appreciate this question. It's great. So there's a couple of things we have to talk about here. Number one, it's true. It is possible that reducing alpha-synuclein can improve the condition in patients that have an excessive amount of alpha-synuclein. But if, as I mentioned before, you have a condition and maybe when alpha-synuclein is not the major driving force, even if you remove that, it's not going to change too much. Number one. Number two, the dogma, and it's a dogma that is the same of Alzheimer's disease. I accumulate an abnormal protein, a cause of damage. I remove the abnormal protein and things should be working better. That is a dogma and is something that maybe is not working all the time. I always say this. Imagine alpha-synuclein as the trash bins that you have in your house. So when you produce trash, you put in the trash bin. And then every week, there's a trash company, usually every week here, some other places maybe less than every week, but every week they come, a big truck removing the trash. And this is what our brain does it all our life. We have a scavenger mechanism that is removing alpha-synuclein. What if at one point you are having a drug that kills alpha-synuclein? What is going to do with the trash? The trash will be all over your house. And maybe you have a condition where the truck company comes every 3 weeks with a smaller truck. So what happens? Let me pass the term, the junk that alpha-synuclein is not able to contain is accumulating all over the house, causing more problems. It's important thing to consider that I don't think, and there's many evidence to support that removing alpha-synuclein will work in everybody. As usual, our effort is to work on identifying who and what works for myself and not for Melanie and not for Amy and so forth. That is an important thing. It can work not only. I agree with the fact that it depends on the stage. Clearly, if we do all the neuroprotective trials that have been done so far on coenzyme Q10, even on Asilet, have been failed. Why? Because likely the condition was too advanced. The condition was already present when there was what? A motor onset. But if we talk about regular Parkinson disease, we know, and I told you before, the disease can start 10, 15 years prior to that. So we want to work at the very beginning, at the inception of the disease for neuroprotection, not when it's already happening for a few years. That is a problem. And I agree. There's a number of drugs that are used for a different condition. Some anti-diabetic drugs, anti-high blood pressure drugs, uric acid, that are showing some biological potential in treating Parkinson's disease in mice. And sometimes epidemiologically, you see some of the association, but depends a lot on the stage. One thing that I want to say that is very important. I've seen a number of cases nowadays, people that are reach out to me with positive immunostain of skin. So they go and do the skin biopsy, searching for alpha-synuclein. And if it's positive, clearly, they're worried, even without symptoms. And they say, okay, do I have synucleinopathies? Do I have a disease like that? And the answer is no. I mean, you might have a deposit of alpha-synuclein in your skin, but doesn't mean that you have deposit in your brain. That is not a surrogate marker of the brain progression. And that is answering this question. We do not have currently a surrogate marker that can tell us what is the stage of the disease. And this is an important thing, because if you don't have nothing in vivo that can tell us, we cannot put the disease at the inception. We can just see and try drugs as things are started. It's a very complex phenomenon, but it's very important, I would say.
Okay, this is a great question. I have a feeling that a lot of people are probably having it as well. It says, she says, and this actually, Pam Quinn says this, I have always taken my drugs in relation to what my day looks like when I need to be on. My doctor doesn't like this because I'm not taking my medicine at the exact same time each day. What is your opinion on that?
It doesn't matter. It doesn't matter. So the answer is that it doesn't matter. You require more dopamine in some days. You need to take more medication that day. What is the problem, especially in later onset Parkinson's disease, but also in young onset Parkinson? Why doctors are insisting on taking the medication at the same time? Number one, because of the food interaction. You know, we know that the medication I heard before was 30 minutes before meals. I always say 1 hour before meals just to play safe, or 2 hours after meals. That's my recommendation, 1 hour before or 2 hours after. So the idea is to keep it regularly. The problem is that at times, some people are having wearing off of the drug. So therefore, you want to have a predictable kind of response. Let's say I take medication at 8, cinema at 8, and I know that every day by 11:30, my medication drops down. So I will take it again at 11:30 and avoid the drop. It's valid point. That's why people want to take it all every single time. But as I mentioned before, if, let's say, Mrs. Queen, she has to teach classes that day, she has like 4 classes, one after the other, she needs more. And it's okay to take more. And it's okay to take in relationship of what you need, as long as you don't present wearing off, as long as you may have a predictable response. Guys, to me, the analogy with insulin is the same. If you are having diabetes type 1 and you work out, and you need more insulin, there's little to say. And this varies according to the day. I hope that one day we will have the ability to measure live as things are needed, the bioequivalent requirement of dopamine, as it happened with diabetes, like with the pumps that allows you to fix the amount of insulin that you need. But we are not yet there, unfortunately. We are really not yet there.
Dr. Savica,
Yeah.
I think I probably speak for several people on this call who are kind of jealous to hear about your individualized treatment, because a lot of us have neurologists who don't do that. And one of the questions in the chat is, how do we access this kind of individualized treatment in the US? Do you have any advice?
Absolutely. I'm sorry. I mean, this is a problem. There is a problem. It has to do, and I am in contact with some patients, has to do with education, has to do with training, has to do with thinking outside the box and sharing the frustration that we are in 2021. 2021, we don't have a cure for this disease. And it's insane to me that we are still banging our head about dopamine and about alpha-synuclein, and we don't know even what is working for, and then we know that is not the case, and so forth. How to have access to that? Well, I don't like to do self-advertisement at all, but at the Mayo Clinic, we do have this opportunity to, and we accepting more patients, clearly. So if you contact us, we would be more than happy to put you in contact with these people. We know there are people, me, basically it's me. There are 2 centers, unfortunately, as far as I'm aware, so maybe there's more, but 2 in the globe, in the world, that are dealing specifically with this approach. Us, Mayo Clinic, and Nijmegen in the Netherlands. And it's interesting because these 2 centers are really working together. We are trying to harmonize our efforts in order to keep things at bay. Don't get me wrong, there are centers all over the US with people that are absolutely expert and they are great in dealing with this condition. But the idea is to try to have a larger view of the patient, not just adjusting the medication, but going a little bit beyond that. That is, to me, a very important and relevant aspect. And to me, what we should do, when I say we, I mean myself, but I'm one voice. Despite I have a big institution behind me, and still one voice, we need to advocate. We need to advocate and allocate. So advocate for more resources to allocate for young onset Parkinson disease. And this has to be advocated, with Michael J. Fox Foundation, even with Dennis Phinney, but you guys are doing, but then with NIH, with the government, to promote and develop training opportunities to increase the number of centers that want to increase their knowledge and want to work closely. That's the important thing, closely with the patient about what to do or what not to do. Because the most important thing is somebody say, oh, what drugs to avoid? Yeah, there are things that you don't want to do. There are things that you want to do, things that you don't want to do. But we are in an era when there's a sea of information online. And you can lose yourself in the sea. You can lose yourself in the sea. So we have to make sure that we have a very good system in place and a good networking. Before Mr. Phinney was mentioning, pandemic is being tough on all of us, and I agree, being tough on everybody, but allowed to accelerate the virtual networking. And since we are talking about a rare disease, Zoom meetings, Facebook pages, Instagram pages can be a great source of opportunity to build up network that can help support each other. As Mrs. Quinn said, and I keep on citing her, I wouldn't say right away, and I would try to meet more people and have more friends. It's up to you if you want to say you have a disease or not. I am not going to tell you what to do or not. But for sure, if you have opportunity to connect, that helps. If you know, oh, there's a center there that can help me with that, that helps. But it's very frustrating to me that 2021, we are still struggling to try to allocate resources and try to see a little bit beyond our own nose in terms of treating patients with young onset Parkinson's disease.
We have a number of questions in the chat that are asking about light therapy and your opinion on that.
Well, that is coming from Australia for the most part. So there was actually, I don't remember if it was, I do apologize, I don't remember if it was Australia or New Zealand. I remember it was in Oceania, I don't remember where it was. There are some, the judge is still out there, the jury is still out there, is not yet judged positive or negative. Clearly doesn't seem to be detrimental. So the most important thing is that, is it harmful? Is it harmful? No, doesn't look like. Is it helpful? That would be the second question. The answer is that we are not sure. Do I have things against that? Not necessarily, as long as it doesn't cost very much. That's my only problem. But the only problem is that the light therapy, and now let's talk about more scientific, depends a lot on the penetration. So anything depends on penetrating the skull. There's a coefficient of penetration that depends on the thickness of each other's skull. And unfortunately, there are some people that have a thicker head, therefore nothing penetrates. Even a magnetic, the magnetic stimulation would not work because it doesn't penetrate the thickness of the skull. So there's a coefficient of thickness that is very hard to predict just by doing that. To the point that once, I'm talking about a few years ago, I was asked to be part of this scientific committee to review one of these possible light therapy as well. One of the things that I requested was MRI. You need to have an MRI or a CT scan that tell us how thick is your skull. Because if the skull is too thick, there's no reason to do that because it would not penetrate. So there's some practical problem. But if from a detrimental standpoint, it's not detrimental, doesn't cause me, you, or anybody any particular issues right there.
Dr. Savika, I have a question about exercise, and this was something I remember you told me a long time ago. I thought it was super interesting and really want to share it with this community. Can you talk a little bit about how you've said in the past for YOPD, young onset, earlier onset, go to regular exercise classes if you can, and then can you talk a little bit about the difference? Like maybe you won't tell your older patients.
Correct. This is an excellent point. Thanks a lot, Melanie. So if somebody, again, give it a typical example. Somebody's 43, 44, 45, 50, fit, always work out. I don't feel that sending them to a boxing class for Parkinson's disease will be of any help. Number one, the intensity training, it's not going to be the same. Number two, psychologically, you will see somebody that has maybe in their 90s that can be you feel that it's going to be your outcome, but it's not. So even psychologically is wrong to me. Third, if you've been always exercising, but even if you haven't exercising, what you need to be doing, you need to test to people your age. You have a condition that limits somehow your movements, but still you are the same age in somebody 40, 50, and so forth. So always tell, please go to regular class. Let's say I will disclose that too. Who cares? I'm a martial artist. I train martial arts. I teach martial arts. Spend hours in the gym, and I tell many of my patients, okay, go and do Brazilian Jiu-Jitsu, go do grappling, go do MMA, go do boxing. Tell the instructor, hey, I do have Parkinson's disease, so I may not be able to get at the level, maybe, but your goal is to go at that level. You got to get that dopamine level higher, and to do that, you need to go to regular classes. You can go to our Parkinson classes, and I appreciate immensely what Mrs. Quinn was doing before, but I say, if you work out all your life, if you're fit, if you run marathon, or if you're a cyclist, you need to measure yourself with people at the same age that you have, even if you have Parkinson's disease. That is crucial. If somebody's in their 80s, it's a different story. So in the 80s, I had to say, well, you know, try to resume little by little the exercise, go to our exercise routine. And sometimes I tell, go to what it is, go to a regular, don't go to a regular one, go to a Parkinson one, because sometimes there's other problems. Let's say in your 80s, you may have problems with your knees that would not allow it to work and move very fast. So something beyond Parkinson that can contribute to Parkinson. What we are doing, we are really trying to develop, and I'm really trying to develop something specific for young onset. But again, nothing has to be specific, it has to be regular classes. It's phenomenal to do that because we need people to go to a higher level of requirement. I give you an example. I follow a patient for now 15 years, young onset patient. He was complaining some time ago because he was 20 seconds behind his friends as he was cycling in Utah. This guy was 53. I said, sorry, sorry, okay, 20 seconds. But you know, if I was sending him to a Parkinson cyclist class, he wouldn't feel good about it. I prefer to be a little bit frustrated about missing few seconds. 20 seconds is a lot in cyclists, I know that, don't get me wrong. But I prefer that, but you challenging yourself to a regular activity than going to a different activity. Make sense?
Yeah, thank you. We have about 3 minutes left.
Okay.
I want to ask a question that also has come up in the chat, and that is your thoughts on neuroplasticity.
Oh, yeah. Well, neuroplasticity is a big word. It's a big word, means that what is neuroplasticity is the ability of the brain to recover, to change characteristics. We are constantly undergoing neuroplastic changes throughout our life. If you guys remember Clockwork Orange, if I have you doing Clockwork Orange treatment, for sure, for 10 years, for sure your brain will be wired differently because I'm forcing you some specific information. I'm exaggerating, but I'm telling that everything that we do every day changes slightly our brain. Clearly, when we were younger, kid, we have a sprouting of millions of neurons and information. As we get older, things are different and not as good, not as fast. The entire goal of working on neuroplasticity is to try to find activities or drugs or treatment that can help rewiring, rechanging the configuration of receptors and neurons of the brain. So far, the only activity that seemed to have a neuroplastic role, that seemed to be working, is unfortunately exercise. It's true. What about reading a book? What about playing Sudoku? What about doing one of these tests online? What about going to a play now that we can go back to plays and theater? Is it helpful? Absolutely helpful. It is part of the other aspect that I work with, pleasure. Do something that is good for you, because this positive, this good feeling, these good fun things help your brain to recover. Later, we're going to talk about music. Some people love music, some others hate music. So find your activity and try to work on that. But are there medication or things that we can do to improve neuroplasticity? Other than exercise, in this moment, we don't have anything pointing in that direction. In the recent past, there were some trials working, for example, on stimulating the stem cells, not stem cells, stimulating the available stem cells that have not yet worked very well. But as usual, we are talking about late onset Parkinson's disease. We're not talking about young onset. We cannot translate the knowledge of that time into our time. That is very important and is the major source of frustration for many of us, I would say.
Thank you so much.
Absolutely.
That was so helpful. And valuable information, and so much of it was concrete. You know, we hear a lot about the research, we hear a lot about studies, we hear a lot about theories, but some of your much, if not most of your advice was really concrete, and that's really, really helpful because we have come away with a lot of action steps that we can take.
Thanks for inviting me again.
Yeah.